Welcome back to Medicine Academic Feast. Today we have with us Dr. Aby Abraham, Professor from the Department of Haematology, CMC Vellore. Sir will be taking lecture on approach to chronic leukemia. I think that's something which we might not be managing, having a management level knowledge required, but then as a medicine practitioners and people, all those who are interested in listening to this lecture will be most wanting to know about the approach to chronic leukemia, because we might be seeing a lot of patients with abnormal bleeding parameters, other coagulation parameters, or any blood parameters which might be abnormal, which we will like to have it approached in a proper way. Sir will deal with approach to chronic leukemia for today. If any doubts through the session, please feel free to ask questions. We can unmute yourself, or you can put down in the chat box. The lecture will soon be uploaded on the Department of Medicine YouTube website. Sir's field of interest is in coagulation disorders, myeloproliferative disorders. So today, thanks again, sir, for agreeing to take this lecture for us. We'll upload this lecture soon on Department of Medicine YouTube website. Please feel free to access that whenever possible. Over to you, sir. Thank you.
Thank you. Thank you very much for the kind introduction. And good afternoon to all of you who have logged in. I'll just take you through the approach to chronic leukemia. This is something which is not common, but at the same time, it's a very important part of hematological disorders. I'll be mostly dealing with CML and a little bit about CLL, because CML is a very, even though it's a rare disease, it is a very unique disease, because CML has many firsts to its name. So it was the first disease or cancer where a translocation in a chromosome was demonstrated to be the causative, the factor, the minute chromosome. All of you have heard of the Philadelphia chromosome. It was discovered by Hungerford et al., and for which they received the Nobel Prize. And it is not surprising that they were rewarded with that prize, because this is the first time somebody demonstrated that this particular chromosomal aberration can lead to cancer. That's an etiology of cancer. And then subsequently, the gene was identified. What is the driving factor in this chromosomal abnormality? That was a BCR-ABL fusion gene. Basically, there are two genes fused together to produce one abnormal gene. And that produces that the product of that gene is what you call the BCR-ABL fusion protein. And this particular protein has much more activity, the tyrosine kinase activity, compared to the naturally occurring wild type tyrosine kinase enzyme. And therefore, it drives the cell. There is a survival advantage to the cells which have this fusion protein. The tyrosine kinase activity shifts into the higher gear, and that helps the cells proliferate and multiply. So again, when it comes to CML, there are many other firsts. This is the first time that enzyme, the protein was targeted. The tyrosine kinase inhibitor was introduced first time in cancer. The targeted therapy was introduced first time in cancer in the case of CML. And again, I'll also take you through the molecular monitoring of how this can be done, because we have a target in this disease for treatment. Therefore, there is a way in which you could monitor molecularly at this particular target. And there is something called, again, it is interesting to know that there is something called a leukemic stem cell. All of you are aware that the existence of stem cells can give rise to any cell in our body. The hematopoietic stem cells give rise to the hematopoietic cells. And there is something called leukemic stem cell. Each leukemia has its own driven stem cells, which give rise to daughter cells. So how do you make a diagnosis of CML? So again, history is the most important thing. And you have to have history properly done. And vast majority of the people are asymptomatic, up to 50%. So it may be quite surprising to many people when they would have gone for a medical checkup for nothing, and somebody told them, okay, their blood count is very high. And that's a commonest way in which CML is picked up. They could present with lethargy, hypochondrial discomfort below the left, on the left side. That's mostly because of the enlarging spleen. The spleen gets enlarged in this situation because of the pressure to produce more blood, because the marrow is replaced by the CML cells, and therefore therefore there is a demand on the body to produce normal cells, and that is extramedullary hematopoiesis. There could be loss of appetite, there could be loss of weight, and there could be low-grade fever. And because of the high turnover of cells, many of them could have high uric acid, and that can lead to gouty arthritis. And in men, a rare situation, where there is hyperviscosity, it could produce preaps. What are the physical findings? You could have pallor, hepatosplenomegaly, and lymphadenopathy. So hepatosplenomegaly is almost universal. Most all of them have varying degrees of liver or spleen enlargement, and very occasional patients could present with just high counts alone. What are the investigations you will do? Of course, you had to do the complete blood count and a reticulocyte along with that. A peripheral smear is very important in this, because that will tell you exactly the garden party appearance. I'm sure all of you would have seen in the clinical path when you had your BBS training. And of course, specialized tests include FISH, RT-PCR or RQ-PCR to look at the BCR-ABL product, and also cytogenetics or karyotyping. So what you see in peripheral smear, like I mentioned earlier, there is absolute leukocytosis, and there is a left shift here. And what do you see in the left shift? The classical, so you could see a left shift in any other, so many other conditions like infections. All of you see almost daily left shift, or it could be because of marrow infiltration or due to any cause. So this could produce a left shift. But here, the characteristic of this left shift is that there is a bulge in the myelocytes. The myelocyte part of the left shift is kind of very prominent. And that is more myelocytes than more mature metamyelocytes. So myelocytes come before metamyelocytes, and there is an increase in myelocytes, almost like, there is a maturation kind of arrest at the stage of myelocytes. Blasts usually number less than 2%. Even though there's a left shift, the blast fraction doesn't go beyond 2%. As the blast fraction goes up, it means that there is increased disease load and the disease is advancing further. That's what it means. Absolute basophilia is nearly universal in these patients, and it's very characteristic on the peripheral smear when you review the peripheral smear. And absolute eosinophilia could happen in up to 90% of cases. So this is a slide of a chronic CML patient. You could see what I described so far. You could see the left shift here, the basophilia, the eosinophilia, the lots of myelocytes there, and this is a characteristic picture. If you have not looked at one peripheral smear, please talk to your friends in clinical path and have a look at that. And it is very interesting to look at this smear. This is a first step toward diagnosis in the lab. And then what else you could see? The panel on the left side, that is the karyotyping. The karyotyping is done by, usually done from a marrow sample, but it could be done in the peripheral blood also. But the yield is better if you are doing it from the marrow. And what do you see there? How do you go about it? The karyotyping, so you had to do a cell culture under controlled conditions. You had to have a higher concentration of carbon dioxide, and the cells grow, and then these cells are separated, and then it is processed and stained. And then once it is processed, it is spread out on the slide, and that's what you see. There is banding. You could see several bands in the chromosome. And this banding is characteristic for each chromosome. And here you can see that there is an arrow pointed there, that on the 22, there is a minute chromosome. So there is a small chromosome. Characteristically, it is smaller than the usual chromosome 22. That's what Hungerford discovered many years ago, for which he and his colleague was awarded the Nobel Prize. So that's what you see there, the Philadelphia chromosome. And what you see on the right side panel. This is a technique called FISH, fluorescent in situ hybridization. What do you mean by FISH? Here you are actually staining it's quite similar to karyotyping, but it's a little more kind of specialized compared to the karyotyping. Here you're putting special stain which has got fluorescence, and this one will go and bind where there is this fusion the chromosome. So that it will produce a color of both green and the pink one. That is what you see on the right side. If there is both pink and the blue one together in one spot, that means it's a fusion chromosome. So one will target 9 remnants and one will target 22 remnants. So it's a 9-22 fusion. So this particular thing, the fluorescence occurs, both color fluorescence together occurs. That's what you are looking at. If that is there, that's quite characteristic. This is more sensitive than the regular karyotyping, which you see on the left side. So FISH is what we routinely do in our clinic because it's relatively cheaper. There are more sensitive techniques, but this is what we generally do. Once you have a clinical suspicion, this is a test after we do the blood counts and the peripheral smear. Here, this particular slide shows the locations of breakpoints. So, like I mentioned earlier, translocation 922 can occur because the chromosome can break from 9 and 22 and become a fusion product. And this breaking of the chromosome can occur at several locations. So, and depending on where the breaking in the chromosome occurs, the product of that 922 fusion product could change. The size could change depending on where the break-off occurs. And there is several nomenclature based on the location of the breakage, like E1A2, B2A2, B3A2, and E19A2. So, is there any relevance to this? Generally, there is relevance in the sense that some are more common than the others. And you would have heard of Philadelphia positive acute lymphoblastic leukemia. And in fact, that is also a condition. It's not CML, but it's acute lymphoblastic leukemia, but very small fraction of ALL. But as one ages, and if there is ALL occurs in the older population, there is more chance of the Philadelphia chromosome being positive in those people. So that is quite similar to the CML in the sense that the Philadelphia chromosome is there, but it's a different disease entity altogether. So there again, this breakpoint will be different from the CML breakpoint. So before I go to the different phases, so this particular breakpoint is picked up by RT-PCR or RQ-PCR. So it is more sensitive. Why don't we do RT-PCR or RQ-PCR upfront? Because we don't do that upfront because suppose if it's a rare variant, you may not pick it up on the RT-PCR or RQ-PCR. Therefore, you have to first really demonstrate a FISH or karyotype before you go into RT-PCR or RQ-PCR. So because you could miss rare variant, but it is much more sensitive than FISH or the karyotype. It is much more sensitive. Now, what are the different phases of CML? There are 3 different phases. Solid tumors can be you say there is staging, because it is organ-specific blood cancer, so liver or bone or whatever, and therefore you can say different stages. But when it comes to blood is everywhere. It's like air is everywhere in wherever you go. So blood cancers cannot really be staged that way, except of course lymphoma, but lymphoma is generally a disease which comes from the lymph node. So therefore, when it comes to blood cancers, we only put them into different phases or grades. Grade means the severity of the disease. There's a higher degree of severity or whether different phases of the disease. So CML has 3 phases: chronic phase, accelerated phase, and blast phase. And the blast phase can be myeloid, lymphoid, or biphenotypic. blast phase. So how do you define these? What is accelerated phase and what is blast phase? So once you define accelerated phase and blast phase, it's very easy to say what is chronic phase. Anything which don't fit into accelerated phase or blast phase will be chronic phase. So you could say that there are both WHO and ELN criteria for this. ELN stands for European Leukemia Network. They have done pioneering work in kind of defining these criteria, as well as putting in place guidelines for treatment, when to treat and when to stop treatment, these sort of things. WHO has been the pioneers in disease classification and diagnosis. We generally follow WHO classification, but ELN is a good system to keep in mind as well. So when you look at accelerated phase, of course, the WBC count is probably very important here, because persisting or increasing WBC count, which is unresponsive to therapy, is definitely one factor for to call it as accelerated phase. Second, I'll say as a corollary, spleen. The spleen which is not regressed in size despite treatment, it means that it is almost similar to high WBC count, persisting WBC count. That means that the disease has not responded to therapy. Then I earlier mentioned that most of the patients with CML present with the blast percentage of around 2%. But if the blast percentage goes above 10%, that means that it is a it could be accelerated phase, 10 to 19%. Anything beyond that, it is blast phase. It's like acute leukemia. Basal percentage, if it is above 20%, again it's defined as accelerated phase. Other definitions include platelet count more than 1,000 multiplied by 10 to the per liter, or less than 100,000. So it's equivalent to 100,000 or 1,000, a million. So persistent thrombocytosis, persistent thrombocytopenia, those are also definition criteria for accelerated phase. Other criteria could include any other clonal findings on the karyotype. There could be additional chromosomal abnormality at diagnosis or at some time during treatment. Extramedullary involvement, if it is present, it is classified as blast phase generally. When we say extramedullary involvement, it could be a skin involvement, it could be a CNS involvement, it could be testicular involvement, or it could be any other organ involvement. Generally, skin involvement is seen as extramedullary involvement. It's an extremely rare event, extramedullary involvement. Liver and spleen are not considered as extramedullary involvement. And again, a response to TKI, again, that is also a criteria to say whether it just fits into accelerated phase or not. Blast phase, it's very simple. Any blast cell more than 20% is considered as blast phase. And if that is a clear-cut definition of blast phase, or if there is extramedullary involvement. Now, what are the diagnostic workup which you do? I had dealt with this mostly in my previous slides, but this slide again says baseline you have to do blood counts and differential. Do you have to do bone marrow at diagnosis? We in the department don't do this on a routine basis, mainly because the chance of finding a clonal cytogenetic abnormality is extremely rare. Therefore, we tend to save the expense by doing only a FISH from peripheral blood. But ideally, you should do this if you are trying to look for a clonal cytogenetic abnormality other than translocation 922. FISH in the blood, yes, it is important test we should do. RT-PCR I mentioned earlier, it is more sensitive, but it's not really required. But qPCR, RQ-PCR should be done as for monitoring purpose every 3 months in the first year, and then every 6 months to every year subsequently. Mutation analysis you have to do. A marrow has to be done if you're suspecting accelerated phase or blast phase, as well as a mutation analysis to look for additional clonal abnormality if the patient presents with accelerated phase or blast phase. Now, little bit about the treatment part. How do you treat CML? Treating CML has evolved over a period of many decades. And I still remember when, as an MBBS student, I walked into C ward, and I don't know how many of you know Dr. A.M. Cherian. He was my first teacher, and my first clinic was taken by him. He taught me how to take a history and how to examine the patient. And I still remember going to and examining one of the first patients with Dr. A.M. Cherian. And it was interesting because we also happen to have his daughter in our group. That's a different thing. Anyway, I still remember examining the first patient, and that was a CML. I still remember that. And it was a big spleen, big spleen he was having. And of course, for MBBS students, that big spleen is easy to feel it. That's why he took us to the patient with CML. And I still remember him talking about busulfan at that time, and even hydroxyurea. And at that time, those were the only two drugs which was available for CML. And it was not curative, of course, but it provided symptomatic relief to the patient. Somebody who came with abdomen filled up with the spleen. This gave symptomatic relief to him, but it did not extend his lifespan. But subsequently, when that fusion gene product was discovered, the TK target was discovered, there was better drugs available. Interferon, again, it's a very effective drug in myeloproliferative neoplasms, but it is not curative again. It doesn't cure the disease. But one advantage of that drug is that if a patient is pregnant, it is safe to use. You will hold the disease during the pregnancy, and once the patient delivers, you could switch back to any other therapy. Bone marrow transplant was again a treatment which is used extensively in the past as curative treatment because none of the other drugs could cure CML. But bone marrow transplant had its disadvantages. One is you have to find a donor. Second, it is a very expensive procedure. Third, it had a risk of mortality during or after the procedure. And subsequently, once stem cell transplant is done, they could end up with graft versus host disease, which is a disease by itself and might require prolonged medications, and it could affect their morbidity. It can cause significant morbidity and significant lifestyle modification may be required. So then comes a new drug, like a new kid in the block. It targeted TKA, tyrosine kinase. That's called TKA, tyrosine kinase inhibitor. And of course, the last one is targeting the leukemic stem cells. So before I go into the details of that, how do you stratify chronic phase? I mentioned about accelerated phase and chronic blast phase. Now, a little bit about how do you stratify chronic phase. So treatment of accelerated phase and blast phase is totally different from chronic phase. And among chronic phase itself, there is subtle differences depending on how you stratify. Stratification is based on the disease load. And there are several scoring criteria like SOCL, which is classical, then Harsford, UTOS, and now there is ELTS, UTOS linked scoring system. So that all these are developed. SOCL was developed before tyrosine kinase inhibitor was available. Harsford and UTOS came later, and ELTS also came later. So based on the age, the spleen and liver size, only the spleen size, and the platelet count, the myeloblasts in blood, basophils in blood, eosinophils in blood, there is a complex formula. It's available freely in the net. Based on that, you could calculate low, intermediate, and high risk. The high risk people might need more intense monitoring because they could progress to accelerated phase or blast phase. They're at a higher risk. So what are the different tyrosine kinase inhibitors available? It all started with imatinib. Subsequently, second generation came. Now we have third generation and even beyond third generation. Dasatinib, nilotinib, bosutinib, and ponatinib. As more and more drugs are available, doesn't mean that they are much better than the initial ones. Just means that they bring the disease under control faster. And also certain settings, this will be useful. There are some mutations which confer resistance to imatinib, and therefore these drugs could be used in those situations. And there are some mutations which are resistant to most of the TKIs, and therefore only ponatinib will be effective. So how do resistance happen in tyrosine kinase therapy? One is the most important thing is compliance. Most patients, like all of you know about diabetes and hypertension, and it is you had to have really good discipline to take medications on a real long-term basis, and compliance becomes an issue when patients realize that they are much better. They feel, why should they continue the same medications? Maybe expensive to them. So there are several factors for this, and compliance is the major reason why the resistance occurs in CML. There are different mechanisms by which it can happen. It could be TK independent and TK dependent modes of resistance. I will not go into the details because that's beyond the scope of this lecture. So how do you monitor response? So one thing which you can, I mentioned earlier that the CML, when it present, it can be asymptomatic, or it could be splenomegaly or high blood counts. So first thing you look at it is their symptoms are regress, whether they're on examination, the splenomegaly and hepatomegaly, if it is there, that is resolved, and then look at the blood counts, whether the blood count are normalized or not. How is the differential count in the peripheral smear, whether that has become normal, basophilia, eosinophilia, shift left, all that has become normal. Despite blood count being within the normal range, TC being normal range, it could still be left to shift. Platelet count has become normal or not, spleen is palpable or not. So if all these criteria is met, that's what we call complete hematological response. Means that patient disease has responded very well to therapy, but that's only the first step. That's the first thing you see, the hematological response. What is the second step? Second is the cytogenetic response. Again, here you have complete, partial, minor, minimal, and or no response at all, depending on the FISH test. So I told you earlier about FISH test. It is a very sensitive test, more sensitive than karyotyping. You can quantify the FISH by counting the number of cells carrying the FISH positive, fusion positive signal. So it can vary from 0 to 100%. So if it is more than 95%, then you can say that there is no response to imatinib at all or any of the other TKIs. And complete means there is no pH positive fusion signal identified in any on FISH analysis. And depending on the different fractions of this, you can call it partial or minor or minimal response. This was the way in which we went about until RQ-PCR became more refined, and you could compare RQ-PCR from one lab to the other using something like INR. There is we use called international ratio based on that. Like PT-INR, this also has a standardization process. So based on that, you call it percentage. So you target the molecular response based on this. There is something called major molecular response. Again, we are doing an RQ-PCR to look at the fusion transcript level, which is less than 0.1%. It is called a major molecular response. And this is what we want at the end of 1 year of therapy with imatinib or any other tyrosine kinase inhibitors. Then there is deeper levels. You can go into MR4 or MR4.5 or MR5, which means that you are controlling the disease much deeper and deeper. That's what you are targeting. Okay, so at diagnosis, there's a huge 10 to the power of 12 cells are there. Then when you see hematological response, which you expect at 3 months of therapy, it comes down by 1 log. Imagine you don't see the disease by conventional features, but there is almost 10 to the power of 11 cells in your body still. Complete cytogenetic response, it is 10 to the power of 9. And then major molecular response, you could still have 10 to the power of 6 cells. And when it goes below that level only, it becomes a deep molecular deep response. And European Leukemia Net, which I talked to you about earlier, this particular thing, they have defined certain guidelines for monitoring, and based on baseline 3, 6, 12 months and subsequent optimal response I mentioned earlier, you are looking at a response of BCR-ABL of less than 10%. Fish is 35. That is no longer followed. If you don't have recourse to RQ-PCR, you do a fish for monitoring response. Only for diagnosis, we use fish. At 6 months, it is less than 1%. At 12 months, it is less than 0.1%, what you call MMR. And there are certain warning criteria here. If it is not falling, if it is falling into that, means that you have to be careful. You have to probably change track depending on where you are. So this is a very important table which we usually follow when we see patients with CML in our clinic. And mind you, all this treatment takes place in the outpatient department. This particular study, IRIS study, is a landmark study. It showed how important MMR is with regard to follow-up of therapy. Why do we target MMR for less than 0.1% RQ-PCR on a national scale at 1 year? Because if you don't get that, there is a risk of progression to ulcerative phase or blast phase down the line. So it is very important for patients to achieve MMR at 1 year of therapy with tyrosine kinase inhibitors. Now, this particular table again tells the same thing. Overall survival, it is 83.3%. And if it is complete cytogenetic response or MMR is there, you can see that it is dramatically much better compared to others. The chance of accelerated phase and blast phase goes up if you don't achieve MMR. Well, now people have become greedy after some time. Now there is a treatment available and it looks like it's an indefinite therapy with the tyrosine kinase inhibitors. So people started looking at, can we stop this drug after some time? So this is mostly in the West because there they have recourse to close monitoring of patients. Patients are more disciplined and maybe because of their education level, maybe not, whatever, they have medical care which is available cheap and it is available quite readily. And therefore, this is possible. So if they have found that it is possible to stop decay provided certain criteria are met. And this is called green criteria. For that, the patient should not be having a high SOCAL score at diagnosis. And then the transcript, the BCR-ABL transcript should be typical transcript, not the atypical transcript. I had mentioned about this earlier in the earlier slides. It should have been a chronic phase at diagnosis, and optimal response to first-line tyrosine kinase inhibitor should have been there, which means the ELN table which I mentioned earlier should have been met. Optimal response should have been met. Duration of TK therapy should have been for at least 5 years prior to this decision being taken, and they should have attained deep MR, which I mentioned earlier, MR 4.5. And duration of this deep MR should have been at least 2 years. If a patient fulfills all these criteria, the green criteria, you could think of maybe kind of withholding tyrosine kinase inhibitor. And mind you, most of our patients don't fit this criteria. This is only for the patient, and there is some institutional requirements. One is you should have an access to RQ-PCR at a very good lab, which does quality control at regular intervals and ensures that their IS reporting, like INR reporting, is proper. And there should be a rapid turnaround time for looking at the RQ-PCR. Patient comes, gives his samples, and within 4 weeks, you should get that value. If you are getting it more than that, the disease might progress, and that will put the patient in danger. Capacity to provide PCR tests every 4 to 6 weeks when required, and the intervention, if the BCR-ABL is rising, that whoever is treating should be able to intervene at the correct time. If all this is met, then it may be worth considering stopping. But this is not something which you don't advocate. Maybe in the older patients, yes, if they have a recourse to second generation and other drugs, and they can afford all those things, yes. If patients who cannot afford second generation or third generation TKs, it is not advisable to think about this. And mind you, we are not started doing this. We don't advocate TK stop therapy for our CML patients. I think we are not reached that stage yet, but it's something which is practiced in the West for selected group of patients and in selected institutions. Now, what is the treatment for accelerated phase and blast phase? Bone marrow transplant, of course, is a treatment of choice here because otherwise the disease will progress. There is no way you can arrest the disease with a magic drug like TKI. The prognosis here is much worse compared to the chronic phase. Now, special situations like pregnancy and older age. Pregnancy, I mentioned, you cannot use TKIs here. You have to switch to interferon and carry the pregnancy through this period and then switch to TKIs once they have delivered the baby. Having said that, we have had patients occasionally who have taken imatinib and delivered normal children, but you won't advocate that as a medical practitioner because they should be told of the side effects of the harm which it could cause to the fetus. Older age, again, special situation mainly because they may not tolerate the drugs like the others, but here they may not tolerate a transplant. So we may not be able to do a transplant. Therefore, it's very important that you provide optimal therapy with TKIs to these patients. Now, with that, I complete my CML part. I'll go into the CLL. There are only very few slides here. CLL is like CML, but there are some similarities. It's not with regard to the biology, but with regard to the treatment available and the way we approach. There are some, of course, some important differences also when it comes to the treatment. It's a mature B-cell neoplasm. And it is characterized by progressive accumulation of mature B cells. Our peripheral blood contains mostly T lymphocytes. Okay, the lymph nodes contains more of B lymphocytes, but peripheral blood contains more of T lymphocytes. But the CLL is a B cell neoplasm. So when CLL occurs, it is mostly the B lymphocytes in our peripheral blood which occurs. It is identical to a non-Hodgkin's lymphoma, but the term SLL is used interchangeable with CLL. SLL means small lymphocytic lymphoma. So CLL is a term which when we use when it is a peripheral blood lymphocytosis. And if the disease involvement is primarily nodal, there is no lymphocytosis in blood, you call it small lymphocytic lymphoma. So it is interchangeable. Blood flows everywhere. Blood flows through the lymph node. Blood is there within our blood vessels. So the disease involves only nodes, it becomes SLL. Disease involves blood also, you call it CLL. And it is the most common leukemia in adults in the West. Why? It's not so common in the Asian countries, especially China and Japan. I presume it's not, we don't have good statistics in our country, but I don't think unlike China and Japan, it is that uncommon, but it is definitely rare. It is rare mostly because our population is young. Unlike the West, which have an aging population. And men are affected more often than men. It increases with age. And like I said, for certain genetic reasons, it's rarer in Asians. When Western people say Asians, they mean Chinese or Japanese population, the East Asian population. What are the symptoms and signs? It's mostly asymptomatic. So here comes the similarity to CML. 50% of the patients in CML are asymptomatic. Here, even more of them are asymptomatic. They could present with B symptoms of lymphoma. All of you know what are the B symptoms. They could present with infection because B lymphocytes are important in fighting infections. It forms part of our immunity. They could have autoimmune features. And what are these? They could present with autoimmune hemolytic anemia, immune thrombocytopenic purpura, because again, this is a disease involving the B lymphocytes, and therefore immune dysregulation takes place, and therefore there can be autoantibodies against the red cells or the platelets. Lymph node enlargement it's a common manifestation. Hepatosplenomegaly is a common manifestation. Leukemic otitis is a rare manifestation. And the lab features, lymphocytosis is the characteristic feature. But can you diagnose anybody as CLL based on just lymphocytosis? No, certainly not. Absolute lymphocyte threshold should be above 5,000. So there are other diseases where they can have lymphocytosis. For example, viral illnesses. So the cutoff is 5,000 per cubic millimeter. Some patients can present with cytopenia, especially due to autoimmune features, which I mentioned earlier. They could have high LDH and beta-2 microglobulin. So mind you, the absolute lymphocytosis is not definitely pathognomonic of CLL, but it's an important characteristic which will tell you that it could be CLL. And how do you make the final diagnosis? Peripheral smear, just like CML. Again, peripheral smear is very important. You have to do a peripheral smear. It will, experienced pathologists will tell you this is mature B cells on the peripheral smear, and it is not blast. If it is blast, it is acute leukemia, lymphoblastic leukemia. If it is mature B cells, it is CLL. So that's why to make the difference between acute lymphoblastic leukemia and chronic lymphocytic leukemia on the peripheral smear. The pathognomonic feature comes from flow cytometry or immunophenotype. To make a diagnosis of CLL, all you need to do collect is 5 ml of blood from peripheral venipuncture and then run a flow cytometry. And it will show B cell associated antigen 19, 20, and 23. And the staining of CD20 is usually low and dim. Generally, 20 stains brightly for B lymphocytes, but here in CLL, it is quite dim. That is another characteristic. Expression of CD5. CD5 is usually expressed by T lymphocytes. Usually the smaller numbers, that's what I tell most people to remember easily. 3, 5, 7 are usually characteristics of T lymphocytes, and the bigger numbers, 19, 20, and all those things goes for the B lymphocytes. When B expresses 5, which is usually expressed by T, that is quite characteristic of CLL. They will also have low levels of immunoglobulin because it's a B lymphocyte. They can mature into plasma cells. Plasma cells produce immunoglobulin, and therefore low surface levels of immunoglobulin can be there. The immunoglobulins which are usually expressed are either IgM or both IgM and IgD. And the most characteristic of to say that this is clonal in origin is to look for kappa or lambda chain of the immunoglobulin. If only kappa or lambda is expressed by one population of cells, it means that it is a clonal population. Otherwise, it can be a naturally occurring mature lymphocyte due to an infection. This is the only way you can say it's clonal in origin. Otherwise, it's polyclonal. So, kappa or lambda restriction in a B lymphocyte clonal population in the immunophenotype puts a nail on the diagnosis. That's a confirmatory characteristic. Will you do a bone marrow in this patient? Generally not. Like in CML, ideally you should do a marrow. We in our center don't do because of the reason which I mentioned earlier. Ideally it should be done. Here again, CLL, there is no need for a marrow examination, but you will do if you are looking at cytopenias. If there is cytopenia or if the patient has B symptoms, you are suspecting something more than just CLL, then you should do a bone marrow examination. All of you heard of Rai staging. Kanti M. Rai is of Indian origin. He is based in US. He's an American pathologist who devised this staging. And he was the first president of American Society of Hematology, first Indian origin president. And you could see that here, this low, intermediate, and high risk based on the stage. Lymphocytosis is there or not, or whether his lymph nodes are there, where there is anemia or thrombocytopenia. Based on these, you stage. And is the stage important? Yes, it is important. This is important because the treatment differs based on the staging. Generally, for most patients, unlike CML, we don't treat because you can watch and wait. It can go for many years without any trouble given to the patient. Like a low-grade lymphoma, also we don't treat. You could watch and wait, follicular lymphoma. So this also you could watch and wait. Patients can go for, many of them are older, they can go for many years without any treatment. If you start treatment, it could cause problems. So unlike CML, here one major difference in treatment is you watch and wait. So I mentioned this, and what is ibrutinib? It's again it's an inhibitor of the enzymes, a Bruton tyrosine kinase. Unlike the tyrosine kinase inhibitor with CML, this is also targeted therapy. Ibrutinib is like imatinib for CML. There are other newer ones around, but ibrutinib is a landmark in the treatment for CML. Again, oral treatment, which is very well tolerated by many patients. So with that, I stop. Thank you for your attention.
Thank you, sir. I think that was an overview into our approach and management for chronic leukemia. Any doubts, please feel free to ask, sir, or can you type down the chat box. So is there any bimodal representation of CML or a CLL that can help in prognostication also?
You mean somebody who presents with both CML and CLL?
Or no, either of in both. Say, as a bimodal representation, is it there in a CML or CLL, which you said age-wise, the prognostication is like as age goes, is it more than 45 years?
Oh, okay. Age-wise, yes. So, yeah. There are younger people also can be affected, but generally that is rare. That is extremely rare. It could be.
Prognostication-wise also it's...
Yeah, prognosis is worse in the extremes of age, obviously. Like any disease, prognosis is worse. And the younger people tend to have worse prognosis. And very old people, for obvious reason, they don't tolerate the treatment well.
Bone marrow transplant is not an option in a CLL.
Yes, younger patients, yes, bone marrow transplant is an option. CLL, yes. Younger patient with CLL, bone marrow transplant is an option. Generally, that's not the...
And the follow-ups, like do we see a recurrence in our patients with a stable disease?
How do you follow up CLL? Okay, so here again, the intention is not cure, except when you are looking at bone marrow transplant. There, the intention may be cure because it's a younger population. You could achieve cure in that patient. Otherwise, it's just control the disease to the extent possible, or maximum control in terms of WBC count. If there is lymphadenopathy, whether the lymphadenopathy has to regress, hepatosplenomegaly has regressed or not.
It's all oral drugs to talk about.
Oral drugs. But having said that, you could give injections. We do use that, like lymphoma, like CVP, RCVP, rituximab with cyclophosphamide, vincristine, prednisolone, R-CHOP. All this can be used because it's essentially like a lymphoma. But it is not required in the vast majority. Bendamustine rituximab, there's another chemotherapy regimen which is useful. We usually don't use that because it's morbidity with that drug. These combinations of drugs, this chemotherapy is much more. Second, if patients can afford oral therapy, it's always better. Like the CML treatment has undergone a change, and ibrutinib was revolutionized CLL treatment. But we don't routinely use for our patient because ibrutinib is very expensive compared to imatinib.
Any questions? We'll soon be uploading this lecture on our Department of Medicine YouTube website. Thanks again, sir, for agreeing to take this lecture for us. I think we'll wind up for today if no further doubts.
Thank you very much.
Thank you, sir.
Thank you.